Good afternoon. I'm Sandra Eldridge and I'm a medical statistician working at Queen Mary University of London in the UK. And I'm going to be talking to you this afternoon about bias in pragmatic trials. The question that forms the title for this talk is something I've been thinking about for a while. I don't have a definitive answer, but I hope that some of the insights I'm going to be sharing with you this afternoon might be useful. So let's start with definitions. First, of pragmatic trials. As Merrick has described, pragmatic trials are those that focus on supporting decision-making, usually about care options for patients, in contrast to explanatory trials, which focus on causal research hypotheses and understanding mechanisms. But it's not really a dichotomy between these two trials, it's more like a spectrum. As highlighted by the Precis-2 tool that Alison described, there may be some trials that have a mixture of pragmatic and explanatory elements. And in this talk, I'm going to focus on trials in which the predominant aim is pragmatic. So for definitions, the Centre for Evidence-Based Medicine in Oxford has produced some helpful information on its website, including an explanation of the development of the word bias from its roots to a 20th century definition relevant to statistics in the Oxford English Dictionary, which talks about a statistical result being distorted as a definition of bias. On the website, they also describe researching terms used in other statistical, epidemiological, and sociological definitions of the word bias, and list the number of times each of these terms was used. Many of these terms pick up similar ideas around distortion, deviation, truth, error, and the idea that this error is systematic, as for example, when darts tend to deviate from their target, but systematically in one direction. From this work, they then provide a definition of bias which expands on the different causes of bias, the different aspects of research study that might be affected, and the fact that the results may be an underestimate or an overestimate of the effect you're trying to measure, the target effect. So to pursue the idea of bias in relation to pragmatic trials, perhaps the first thing to ask is, what is our target? And I'm going to suggest that the answer comes in three parts. First, we want a result that will be helpful for decision-making, an important part of pragmatic trials. Second, we need something that's going to be relevant outside a trial context, also an important element of pragmatic trials. And third, we want a result that is based on robust evidence. So let's unpack these three aspects a bit more. Decisions are not usually made in a vacuum. They apply to specific populations in particular settings. And there are often choices about new interventions versus control interventions. And the control intervention is very often in pragmatic trials current practice, though it may be something else. If these aspects aren't right in a trial, it will not help decision making. If we make a decision with a population, setting, intervention or control, which doesn't really help decision makers, then we can consider that our result may be biased. Secondly, if our target is a result helpful outside a trial context, then we're usually less interested in the results that occur under, for example, ideal adherence conditions, but more interested in results that will pertain when individuals are given the freedom to respond to interventions as they would in usual practice. In other words, we want them to be able to choose how to respond to prescription drugs or other interventions in the way that they normally would. What we want to measure then is the effect of offering people the intervention with flexibility around their behaviour and accepting it. We don't want to measure the effect of perfect adherence. And thirdly, we want the result of the trial to be an appropriate measure of the difference between offering the new intervention and offering current practice or whatever our control intervention is. For this, we need randomisation, which facilitates a fair comparison between trial arms, as Merrick has already described, in terms of the participants involved. But we also need appropriate outcomes, appropriate analysis, and appropriate design. Bias may occur if something to do with any of these factors causes a distortion in our statistical result from what we really want for the decision-making outside a trial. So it would be lovely to think that we could have a full checklist of all the aspects relevant to bias, although I'm not over fond of checklists, but unfortunately, in any case, such a checklist is not available. The Cochrane Risk of Bias tool, which has recently been updated to version 2, has domains which cover randomization, making sure that the interventions are as intended, and various issues to do with outcome measurement. But these only really deal with aspects of internal validity, the degree of confidence about what is going on inside the trial. They don't really cover external validity, which is to do with the results being applicable outside a trial setting. Similarly, the PRACY2 tool may be helpful for assessing whether a trial has actually achieved its targets in a number of aspects, including the flexibility that might be expected outside a trial, as I described earlier. But it doesn't cover randomization, nor does it cover directly the issue of how far the intervention and control conditions match what decision makers might be interested in, only whether they would be feasible outside a trial context. The PCOS framework could also be used to think about how far population intervention, control, outcome, and setting match what decision makers might be interested in. But like PRACY2 and the Cochrane Risk of Bias, this doesn't cover everything that we might be interested in terms of bias. However, it's a useful starting point in terms of understanding how trial design might cause bias. So let's have a look at trial design. If one of the targets of pragmatic trials is for our population intervention, control, outcome, and setting to be chosen in a way that helps decision making, a trial may produce an off-target or biased result if the inclusion criteria are too restrictive, for example, or if the intervention is not as it would be outside a trial, i.e. if the intervention changes too much about an existing system, or possibly too little about an existing system, so it doesn't reflect what would happen outside the trial. Or if the control is not as it would be outside a trial, and one of the most common areas in which this happens is problems with usual care. So the usual care as carried out within a trial is sometimes not what usual care is outside the trial. Also, if outcomes are irrelevant for decision makers, and that includes both patients and clinicians, or if settings are atypical, for example, in single centres or in specialised centres that don't reflect the settings in which the intervention might potentially be used outside a trial, then bias may ensue. Trials need to be designed with this in mind, and much of this is covered in PRACY2. However, even if the PCOS are designed to be helpful to decision makers, bias may occur because of these things are pushed off course in a trial. In spite of the best intentions, many trials are not inclusive enough, often excluding the very individuals that most need treatments. One example being the many COVID trials in which population groups most severely affected by COVID were not adequately represented in trials. Interventions may not be as intended for a variety of reasons. If this is just mimicking what might happen outside a trial context, that's fine. But if it occurs because of something happening in the trial itself, that may be a problem. And I'm involved, for example, at the moment in a trial encountering this sort of problem. The intervention is having to be watered down because of logistic issues which are happening within the trial. Similarly, the control arm of the trial might get contaminated by the intervention, or if there are changes happening in usual care, it might mean that by the time the intervention gets implemented outside a trial, usual care will not be the same as it was in the trial. Both of these could cause bias. And then depending on the outcomes used, if these can be influenced by preconceived ideas by participants or outcome assessors about which treatment in the trial is best, then this may also cause bias. Finally, in some trials, settings may be changed during the trial because of logistic reasons, and that may make the trial less useful to decision makers. But the second element of our target is to ensure that what goes on in the trial matches as far as possible what will happen outside a trial context. This means allowing appropriate flexibility in both the delivery of the intervention and in its adherence, as I've already alluded to earlier. If this is not allowed, this may cause bias. But probably one of the most difficult elements to deal with in thinking about bias in pragmatic trials is that outside a trial context, individuals receiving a treatment will know that they're receiving that treatment, but they won't be in a trial. In an explanatory trial, we switch this around and put people in a trial, but we don't tell them which treatment they're getting in order to avoid certain sorts of biases that could occur. But in a pragmatic trial, there's a tension if we do this, because it's quite far away from what will happen outside a trial context. There has to be balance between different types of bias and which is going to be the most detrimental for the trial, and this may take some consideration. Finally, if we want to have robust results, the third element of my understanding of what we're targeted at, we have to consider the design and analysis aspects of the trial, including ensuring robust randomization and robust design that avoids known aspects of bias. And I've mentioned one particular aspect of design here in relation to cluster randomized trials, identification and recruitment bias, which can mess up the fair comparison between intervention and control participants that randomization seeks to establish. Further, when outcomes are assessed, that needs to be done in a way which minimizes the chance of strongly held opinions about whether the intervention or control condition is better, influencing the outcome assessment. Having a measurement such as death, which cannot be subject to this influence, or making sure that assessors are blinded to whether those they are assessing are in the intervention or control group, are both ways of avoiding this bias, but both options can be more problematic in pragmatic trials. For example, if blinding is difficult or objective outcomes are not relevant to decision makers. Nevertheless, it's absolutely vital to think about sorts of bias that could be introduced in outcome assessment, because there can be creative ways of minimizing the bias in pragmatic trials. Doing the outcome assessment in the first place is deviating from what would happen outside a trial. So there's no problem with trying to get this process as bias-free as possible, unless that places significant burden on participants, which is virtually never the case. Similarly, bias can creep into the analysis in a number of ways, and it's worth spending some time thinking about how to avoid this as much as possible, both in the design of the analysis and in the process of developing the analysis plans. So this talk has been focused on what bias means in pragmatic trials, but I thought I'd put in one slide about what to do about bias and possibly what not to do about it. For me, dealing with bias in a pragmatic trial is a bit like trying to balance on a many-pronged seesaw. There are so many elements that could potentially lead to an off-target or biased results. Dealing with them is about balancing what we do about different elements, bearing in mind how serious we think the effects might be. This includes being careful about the design in terms of the types of trial and the PCOS, and conducting it carefully so that unnecessary bias does not creep in. Allocation concealment in randomization is vital, and if outcomes could be influenced differently in intervention and control groups by assessors, so is the blinding of outcome assessment. Both of these actions are advocated in the PROBE framework published in 1992, which suggested that these actions might be sufficient to avoid bias in some explanatory trials without the necessity of blinding participants and those delivering care. And there is some evidence to support that. In fact, blinding of participants and caregivers is often not possible in pragmatic trials, but it also may not be sensible. For interventions which try to change behaviour through information, education, or talking therapies, for example, the mechanism of action is intended to be through the brain, and blinding does not make any sense because it may remove some of the information that is part of that mechanism. In fact, the thing to keep in mind when trying to address bias is that bias doesn't occur because of a lack of blinding, but because of the distortion of an effect. If blinding can help with that, all well and good, but on occasions it might introduce more distortion than it solves. So to conclude, bias is about the distortion of an effect. To assess bias, we need to know what the aim or target of the trial is, to see how different factors could then distort the effect that we want to measure. Lack of blinding of participants and caregivers does not necessarily indicate bias. It's simply one method of minimizing possible distortions which may or may not be relevant. And I hope I've shown that biases in pragmatic trials relate to both internal and external validity. Some can be judged by the Cochrane risk of bias tool. Others are related to the domains of PRACY2, but not covered in the risk of bias tool. And potential biases need to be judged on a trial by trial basis, with designers and assessors coming to some measure of balance about what might and might not be important. Thank you for listening.